Thanks very much, Shehrad, and thank you to Javed and Bob for the invitation. It's a real pleasure to be with you. Could I get my slides up, please? Just while that's happening, so let me tell you a bit about myself. So, I trained originally as a GP, but work now as a paediatric allergist, my clinical role. And in Edinburgh, about 5 years ago, we merged primary care and public health, two academic departments. These are actually two of the oldest academic departments in the world in those disciplines, and we created a Centre for Population Health Sciences. Last year, so just a year ago, we transitioned into an Institute of Population Health Sciences and Informatics, because we see this as a kind of an area of really very important development going forward. A few disclosures just to share with you. So what I want to do really in the context of this session is have a think about how we can begin to use some of the data that are accruing in our health systems. And I'm going to use the UK as an example, but I think I think hopefully a lot of what I say will resonate with many of your countries, and I'm particularly sort of encouraged to hear that Qatar is going digitized in a whole-scale way. And I think if we can begin thinking of these issues up front, we can really begin to sort of capitalize on the enormous opportunities. So I'm going to share with you a number of examples of the studies I've been involved in. Actually, there are hundreds, but I'll just share with you a few just to by way of illustration. And then what I want to do is actually think about how we move beyond individual research studies and think about actually scaling this up as on an industrial model to really derive some meaningful benefits. And towards the end, what I want to do is have a think about, well, what does this mean for the future of undergraduate and postgraduate education? So a bit of context, and I think many of you will recognize this from the Olympics. It's NHS is our pride and joy. So this is a slide that the Commonwealth Fund produces, so David Blumenthal and colleagues from New York every year, and it looks at OECD countries, ranking them against the Institute of Medicine's 6 axes of quality of care. And as you can see, the UK does pretty well, really, in that respect. So it's a pretty lean and efficient system. And there are a number of reasons for that. It is a rational system. It's a system that extends from cradle to grave, free at the point of delivery. It's funded through a rational mechanism. I think other key advantages are that what we have is a gatekeeping function and a coordination function. So there is a longitudinal element there, and of course we have great specialist providers as well. So I think it's a very, very effective system overall, but like all of our systems, it's cracking at the seams. That said, I want to go back to this graph here, and if you just follow the arrow, the circle at the bottom, you can see although if we look at the kind of standard parameters of quality of care, we do very well. But if we look at outcomes, we do not do so well. And the reason for that is pretty obvious. I think anybody who studied sort of population health sciences will know that healthcare is only a very small bit of the equation. So when we talk about our hospitals, our health systems, yes, they're important, but health is won or lost outside. It's those wider determinants of health. And so what we need to be doing, and I guess I understand you've been hearing about this, so this is a triple aim. What we need to be doing far more in the UK is thinking about the population health dimension. And that's what I've been trying to do. And I think one of the advantages that we have is that we have this digitized infrastructure that extends across the life course. And because particularly we have a unique identifier. Now, in parts of the world, in the US, that's an illegal discussion to have, I know. But I think in places where you have that choice, it's absolutely fantastic, because what you can do is you can begin to link up disparate data sets and really begin to exploit the potential from these. And I hope very much that you will do this in Qatar. So let me just give you a few examples of the ways we've been using these data. So our chief medical officer a few years ago, Liam Donaldson at the time, Sir Liam, was rolling out a COPD strategy. And as you know, when you roll out public health strategies, actually these strategies tend to exacerbate health inequalities unless they're targeted. So he's asked us to look at the data, mine these data, and identify hotspots areas of the country that really needed to focus attention on. And so we were able to do that, and the strategy was then able to be tailored appropriately. So using relatively simple descriptive data. Sharad mentioned I'm interested in respiratory disorders and allergic disorders. So this was an example where we took a healthcare data set and linked it with an educational data set. So this was a question knocking around in literature: does asthma increase the risk of poor educational performance, a long-term condition? As a result of linking these data sets, we were able to put this question to bed and show categorically in the UK that no, it doesn't have a detrimental impact. And you can begin to think how you can do this really for a range of conditions. Until recently, we were using the Framingham cardiovascular risk algorithm. For those of you who've been to Framingham will know it looks like nothing like London. It's a completely inappropriate data set for us to be using in the UK. So what we did is we decided to derive our own data set, and we did this by constructing a 10-year longitudinal cohort. So we took GP data, linked these with hospitalization data, linked these with mortality data, and derived our own equation and then validated that. Now that's been done in something like 30 million patient years of data. So that's probably orders of magnitude bigger than Framingham. And this is a risk algorithm. We make it available to our patients, and you can go in there, put in your own profile and work out your own cardiovascular risk profile. We've done that for diabetes, we've done that for COPD. So we're doing this now for a range of long-term conditions, predictive analytics using our own data. This is another question. So the FDA recently raised this issue about varenicline and its safety. It's the most effective smoking cessation treatment. So an example of a pharmacovigilance study. And what we did is we did a big sort of retrospective cohort study using another linked data set, and we're categorically able to show that actually there was no increased risk of these cardiovascular or neuropsychiatric outcomes. Actually, this has just been replicated in a trial published in The Lancet last week. But we were able to do this at next to no expense, at scale, and begin to really definitively answer these questions. In Scotland, where I come from, our First Minister, our government is pretty left-leaning. So we're very interested in health inequalities. And so what we've been doing is constructing heat maps of chronic disorders and how they vary by ethnic and racial groups. So in this case, what we've done is we've taken our census data. So this is on 4.9 million patients out of 5.2 million patients. So over 90% of the population. Link these with GP data, link them with hospitalization data, and link them with mortality data. So this is the first time in the world that this has been done. So these are done incredibly securely. Census data, are probably the most secure data that you can get within a sort of a healthcare domain potentially. And what we can see is there are enormous variations in this disease, and actually we're seeing this from a range of diseases. And what we tend to see is that South Asian origin groups tend to do particularly badly. Chinese origin populations do particularly well. But when we look at readmission, so when people come into hospital, actually the care is equivalent. So actually the variation of care is out in the community. But you can begin to do this in real time and then look at the impact of various attempts to reduce health inequalities, so policy evaluations. So I want to move on to policy evaluations, because this is where health is won or lost. And this is what I was getting at with the question, really. Because most of our policy evaluations go unevaluated. Complete wasted opportunities, really. So in London, we recently introduced the low emission zone. I think it's the first attempt in the world to try and ban heavily polluting vehicles. Now, the premise for this is it will improve respiratory health. A great idea, but does it work? Well, actually, what we've done is we've linked our healthcare data set with pollution and meteorological data, and actually shown, well, at the moment, it's not working. So before anybody else decides to scale this up, take it to other cities, well, actually, the jury's still out. We don't quite know how to make this work. Great idea, but does it work? Let's take another example. So Scotland led the way in terms of smoke-free legislation. I think many countries have followed. And this is a piece where we recently pulled together the evidence on this. So a number of unanswered questions. One of these was looking at the impact on perinatal outcomes. So what we did is we took 10 million births across the 4 nations, did an interrupted time series analysis, and looked at what would have happened so a counterfactual scenario if the ban wasn't in place. And we're able to show a 10% reduction in perinatal mortality as a result of this. So policy evaluations can work, but not necessarily so. And the thing is, these need to be evaluated. So this one clearly works, and so the world should go out and replicate this, but not the low emission zone at the moment. A few years ago, pandemic influenza hit us. So this was an example of a communicable disorder. So interventions were rolled out in real time because policymakers had to, but we need to evaluate what's going on. And so what we did is we took those same data sets I was describing, but linked this with a virological data set. And what we were able to show was, for the first time at a national scale, that those vaccination programs, those antiviral treatments that were initiated, actually caused an improvement in outcomes nationally. The difficulty was this: that the permissions took us 3 years to get. So we get an answer far too late for policymakers. So what we now have in place is a grant where we have lined up our data sets. We've got all the permissions in place. So God forbid, if there's another pandemic that hits us, we can get real-time answers emerging for our policymakers. That's where we need to get to. I want to move on just a little bit, because these are really just by way of illustration. I could go on forever, really. So trials. So what we need is, if we're going to think about this population piece, we need much bigger trials. So this is a trial looking at medication safety. So what we've identified are important medication errors that potentially translate into harm, serious harm, and introduced a skill mix intervention into practices. And what we did, this is a big trial. This is over 500,000 patients randomized in this trial. A big cluster RCT showed a dramatic improvement. But you can only do these kind of trials efficiently if you are using routine data, both to enroll but also to follow up long term. And so one of the big issues that we have been going forward in terms of our trials is what we struggle with is the recruitment piece. So again, what we're trying to use is our electronic health record infrastructure, and to do this proactively. So we're creating a mechanism by which patients can sort of hold up their hand and say they're willing to be interested, they're interested in participating in studies, give permission for their electronic health records to be interrogated against various exclusion criteria. So we bypass the busy health professionals and only invite people when they're eligible. And what you can do as a result of that is you massively increase recruitment, and you actually shave years off trial recruitment periods. So it's another example of the ways in which you can begin to sort of explore these data. But all of these are, at the moment, they're bespoke examples. And what we want to try and get to is actually think about how we industrialize this. How do we really scale this up? And the idea that we're beginning to work with is, again, from the Institute of Medicine. It's the learning health system architecture. And hopefully many of you will be aware of this, but basically what it is it's about provisioning data in real time, interrogating those data against various kind of standards that one puts together. They may come from guidelines or whatever, and actually feeding back those data using appropriate visualization tools in real time, so that people in the front line can actually drive forward quality improvement on an ongoing basis, but in a scalable way. So it's happening across the entire health system. And whenever there are issues that are arising where we do not know the answer, that should trigger a research loop. So that's what we're trying to do at scale in the UK. Now, what we have to do is, to do that, we need to really scale up our workforce, our informatics workforce. What we have got are great clinicians, but for the future, we need people who are informatics trained. And one of the ways we're doing this is through the Farr Institute, after the British demographer, William Farr. So it's becoming one of our national institutes. And these are the areas that we are focusing on as we try and do this. And I'm very happy to share sort of any of these slides with you. But you can see training and capacity development is an absolutely fundamental issue here. And so if we're going to really do this, what do we need to have a think about? So this is our dean, who also heads up the Medical Research Council, so the equivalent of the NIH. And what he's decided is that we're transitioning from a 5-year to a 6-year curriculum as of, the forthcoming academic year. And part of that transition will be every single one of our undergraduate medical students will be obliged to get a basic competency in informatics. I think that's the first time in the world that's happening, but I think it gives you an idea of the direction of travel. Now, what will those clinicians do? they need to understand sort of these issues about human-computer interaction and the ways in which sort of consultations really need to occur. And what we need to do is actually ensure that, I mean, the technology that we have now available is an enabler. It doesn't get in the way of the consultation. So that, I mean, in part, it's those kind of issues. But I think, I mean, just sticking to the piece that I'm sort of trying to propose here, is if we look ahead, I mean, some of the data sets I've been describing are really just the beginning. We're going to have a very, very rich data sources emerging going forward. So even within healthcare, we've got enormous data assets, but these are some of the data sets that we're going to need to be thinking about in the future. So what we have in the FAR Institute has been healthcare data sets so far, but what we are about to do is bring in our genetics, our omics, our imaging, so that deep characterization of our populations. So those data sets will come in to our electronic health record architecture in due course. What we want to do is bring in this wearable dimension. I mean, this is completely unexploited at the moment. There's nobody really doing this. What we want to do is scale this up, bring this in, because it's a phenomenal data asset, and I'm sure we're going to discuss this later on in the course of this session. And looking ahead, I mean, this is just a sort of a cover from the Harvard Business Review recently. This Internet of Things. Well, I mean, our sources of data are multiplying, and what we need to do is really harness these if we're going to generate some useful predictive algorithms. So if you look at some of the best predictive algorithms at the world at the moment, I mean, Framingham, for example, it's got an R-squared of about 0.46. So most of the variation we do not understand. And unless we bring in some of these kind of additional data sources, we're never really going to get there. So that's just thinking locally in the UK. And what I've been doing with Harvard is launch this program. And actually for MENA countries, there are scholarships available. So for those of you from sort of the Middle East, have a think about this for some of your bright young things, your stars of the future. What we're trying to train people to do is understand informatics as it relates to safety and quality and population kind of issues, and be thinking at the macro, meso, and micro levels that were described earlier. So giving them that leadership piece, bringing them into the sort of world leaders, really, because what we need are people who are trained to really transform health systems going forward. So we've just completed the first year, just kicked off the second year cohort, an absolutely kind of fantastic experience, because I think what we need to do is really increase our capacity in this globally. So in summary, I mean, I think in parts of the world, sort of, I mean, oil is kind of drying up and being replaced by other assets. But I think going forward, I mean, as far as I see it, what our real asset is data. This is our kind of new asset, and our challenge is to make this as liquid as possible. I think if we can begin to link these data assets, then they become so much more useful. But what we need is a workforce who can really exploit this. I think there's a major play going on in the UK, and I think whichever countries really move first in this respect, there are massive, massive job opportunities in that respect. I hope that's been of some help. Thanks very much.